So oral and oropharyngeal cancers are both squamous cell carcinomas. But the difference between the two is oral cancer is exophytic. It's an outward growing and often ulcerated. Oropharyngeal cancer is endophytic. It grows inside, inward, into the subepithelial tissue. The site, of course, the oral cavity, most common cancers are in lips, anterior tongue, floor of the mouth. However, the oropharyngeal cancers are mostly in the tonsils, but you could see them in the base of the tongue and soft palate. HPV is involved in both cancers. We see more of oral cancers still related to tobacco, alcohol, and chronic irritation. And then the most common cause of oropharyngeal cancer is HPV, particularly HPV-16. So that makes visual examination of the oral cavity a very effective tool of detecting oral cancer lesions. However, it's not the same for the oropharyngeal cancer. The reason is the cancer is appearing in the tonsils. The tonsils have, on the surface of the tonsils, there are something called tonsillar crypts, which are invaginations that are dipping into the deeper layers. And these invaginations provide access of the virus into the basal epithelial layers. That is where the proliferation and cancer development starts. And from there, you grow deeper into the tissue. Something else happens here is that when HPV infection is persistent, there is an overexpression of two particular proteins, viral proteins called E6 and E7. And these two proteins have a role in the cell cycle dysregulation, and they result in epithelial differentiation and oncogenic activity where the cancer starts to develop. The first presentation of oropharyngeal cancer is nodal metastasis, an enlarged neck node. And of course, as a pathologist, I have to show you cancer pictures. So I wanted to show you here, if you can see my mouse, this is a cancer arising in the tonsils. And the surface epithelium here is not malignant. This is benign squamous epithelium, but it's undermined by this poorly differentiated squamous cell carcinoma. In high power magnification, you can see these are the poorly differentiated squamous cells. And in the background, you could see the residual lymphoid tissue of the tonsils. And then we use immunohistochemistry stains to highlight various types of cells. And in this case, this stain is CK56, is a high molecular weight keratin marker that highlights all kinds of squamous cells. So the benign on the surface and then the tumor underneath invading here. So this is a very nice way to demonstrate how the tumor is growing downwards. And if, for example, a skin cancer is a squamous cell carcinoma, you would see the tumor a lot of times is exophytic, is coming out. Then P16 is a marker. It's a surrogate marker for oncogenic HPV. And we use this in squamous cell carcinomas. And when it's like positive like this, where you have the deep brown, diffuse block-like positivity, then we know that this is HPV-related cancer, or there is a link to HPV with this cancer. So the key takeaway from this comparison is that oral cancers announce themselves, but oropharyngeal cancers tend to hide. And because of that, we started to think about HPV testing for the oropharynx. We noticed that oral cancer has care because patients go to dentist. There is a screening done at the dental office by the dentist and dental hygienist. They look for oral cancer. The American Dental Association has recommendations on screening for oral cancer. But the HPV-related oropharyngeal cancer is a neglected child. Of all HPV-related cancers, it is the one that doesn't have any recognizable guidelines to screen. and the cancer is consistently rising, and there is no effective screening test. So we decided to shift our focus in developing the HPV test into the oropharyngeal cancer. And then I'm going to share some trends. 60 to 70% of oropharyngeal cancers in the United States are HPV related. The rate is consistently increasing, approximately 3% per year. It's more in men, and the incidence is rising worldwide, and the highest burden is in North America and Europe. While researching, I was personally shocked when I came across this paper that shows that in America and the United Kingdom, there are more men with HPV oropharyngeal cancer than women with cervical cancer. A great case to demonstrate the success of cervical cancer screening that has been happening over decades. So with that, we started to study more of the oropharyngeal cancer, and fortunately, it has a better prognosis. And again, if there is a tool for early detection, that prognosis will even improve. And we felt that the testing would fill the gap, this diagnostic gap. So in our conversations, we heard that oropharyngeal HPV squamous cell carcinoma has no known precursor lesions. And the key word here is known. And we questioned that, and we said, well, let's talk about precursor lesions in other areas. Colon cancer, the colonoscopy is an effective screening tool, and the precancerous or precursor lesions are the adenomatous and serrated polyps. Same thing in the breast. Breast, you could, if you look at mammograms or self-examination, both are tools that can be performed to identify a small lesion or a small lump that, when removed, hopefully, you are still in the in situ stage, in the ductal carcinoma in situ or any early cancer lesion. Detecting these, of course, improves patient's prognosis. Same thing with the cervical cancer between the pap smears and HPV testing. And now Roche's HPV test is approved for primary screening. So now we were looking at this, and then we tried to compare that case with oropharyngeal cancer. And we are asking, is it possible that oropharyngeal cancer is the only squamous cell carcinoma that has no precursor lesions? Of course not. This would be like someone not doing colonoscopies and claiming that colon cancer does not have a precursor lesion. The precursor lesions are there. However, we're not really looking at the right patients or looking at the patients in the right time. We don't have tools that would allow us to enhance the patient selection that would let us get in at the time where we have a better chance of getting this precursor lesion. So we identified this as it's going to be a screening test. So let me walk you through what, in general, would be the characteristics of an ideal screening test. It is a test that detects disease in asymptomatic individuals, has a high sensitivity. That means low false negative numbers, high specificity, which means low false positive numbers. It's simple and easily performed, cost effective and scalable, safe and acceptable, and most importantly, it leads to an improved outcome through early detection. So I'll walk you through the resistance to testing with the questions that we get from colleagues that we talk to about the test. So the first one is, HPV spontaneously resolves. Why do you have to test and give patients anxiety? So first of all, we do this to women every day. Women do HPV testing on their pap smears. HPV in the cervix resolves spontaneously, but no one is making an argument that we shouldn't be testing women for HPV on their paps. The idea here is that HPV resolves on its own, yes, but there's a small percentage that have persistent infection, and it is the persistent HPV that is linked to cancer development. And of course, what we're presenting here is just what I'm presenting today is just ideas that we have, recognizing that there are no existing guidelines. So I'm sure that not every persistent HPV infection leads to cancer, but the pattern of cancer is closely associated to persistent infection. So how can you identify the patients who have persistent HPV infection without really testing for HPV? Then the other question, which I believe is legitimate, because when the test was not available, now you have an available test of oropharyngeal swab. What do we do with the positive patients? And we started to do research and to try to come up with intelligent answers supported by literature. So number one, because it's a new test, so we felt that there is a need for healthcare provider education and patient education. So the main thing is to tell the patient before testing that, number one, testing positive doesn't mean that you have cancer. Exactly the same thing that's being said to females doing pap smears. When they're testing positive, that doesn't mean you have cancer. It just means that we need to repeat testing, and this number is arbitrary, 16. It should be somewhere 16, 12 to 24 months to repeat the testing and to identify if the patient has persistent infection. And what we propose is that if the patient is proven to have persistent infection, then they can get referred to an ENT specialist. And we had conversations with colleagues in the ENT space. And one group, for example, here in Pasadena, they told us that they can put the patients in an active surveillance, a group in LA. And then I'll share with you something about ultrasound testing here in a couple of slides. But on the other hand, we never claimed that HPV in the oropharynx is the end of it. This is just the beginning. It should be a tool to identify the high-risk patients so you can do further testing on them. So we are currently in our lab looking at a cytogenetic test that can detect gene amplification markers that may help in predicting cancer, squamous cell carcinoma development. The other thing that we found in the literature, which was interesting, is that there is a study that said that in post-infection vaccination can have a role, recognizing that HPV vaccine has no therapeutic effect. But the study here shows that there is a potential role in decreasing the risk of reinfection and persistence. And I think that this is really significant. This is a study from Denmark where they have looked at a small sample, but they looked at a transoral ultrasound. It's a small footprint probe that can be inserted orally, and looking at the oropharynx. Of course, I'm not an ENT, so I can't really judge that, but I felt that this would be a good tool, that you're not going to do it for everybody. You're just going to do it for the patients that are persistently infected or the higher risk patients. And that could be something to be studied in the future. I'm sure that this would not be, this would be too small to base the approach on, but maybe future studies can show value here, but it's specifically for oropharyngeal cancer. So the other question is that this test it results in unnecessary expensive investigations, and PCR testing, the cost of PCR testing and retesting cannot be compared to the cancer treatment and surveillance. This one study here showed that the estimated cost of $140,000 per new patient for the first 2 years. That's not counting additional cost. The cost of wages lost or loss of productivity of the patient and the caregivers. So basically, we are not really claiming that we're going to test everybody. It's just a way for us to enhance the selection. So you look at the general population, you look at the high risk. You say, who are the high risk patients? High risk patient would be patients with multiple sexual partners, someone whose partner tested positive for genital HPV, patients that have reduced immunity, HIV positive, diabetes, smokers. These can be tested, and then you retest. I can make an argument that you should be testing every sexually active person, but let's just start with this because this is better than what we are doing today. Retest the positives and then refer the persistently positive to ENT, and then continue follow-up according to the clinical need. But testing here also has an impact on the patient because it's not just assessing the risk. Testing positive pulls the patient into a preventive care loop. And once patients know that HPV is transmissible, vaccine preventable, they engage in more screening and in vaccination conversations. It does also, there are studies showing that there is an impact on sexual behavior because testing positive can become a teachable moment for safe behaviors, and testing prompts dialogues on vaccination and prevention, and a mild short anxiety is offset by the long-lasting behavioral effect. The other thing that I always say is that in the oral cavity and the oropharynx, you hear the story of cancer patients about lesions that they had for months that they kept ignoring. A patient who knows that they are positive for, or maybe persistently positive for HPV will not ignore any early sign of cancer. So my final message is that if cervical HPV testing motivates safer behavior and strengthens preventive engagement, there is no reason for oropharyngeal HPV to do less than that. The biology and the psychological triggers are exactly the same. Awareness leads to prevention. And my vision as an optimistic person that I hope that historians of medicine in the future will say that HPV related oropharyngeal cancer stopped rising when we started screening for HPV. Thank you so much, and I'm sharing some references here that I used for this talk, and this is my email. If you need to reach out to me, please do so.